Thank
We are
you.
still live.
A very good evening and welcome everyone. I, Dr. 𝗛𝗘𝗔𝗟𝗓𝗓, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion. On the occasion of World Patient Safety Day, Voice of Healthcare and Walters Kluwer have taken an initiative to bring together the experts and speakers for this resourceful discussion today. In this discussion, our speakers will talk about the effect of medication errors on patient safety and how we can enhance patient safety by reducing these medications error with the help of technologies like CDSs. So now I would like to commence this session by introducing our eminent speakers. Dr. M.I. Sahadulla, he is Chairman and Managing Director, KIMS Health. Welcome, Dr. Sahadulla.
Hi, welcome.
Dr. Sanjeev Singh, he is a medical director, Amrita Institute of Medical Sciences, Delhi-NCR, and chief medical superintendent at Amrita Institute of Medical Sciences, Kochi. Welcome, Dr. Singh. Dr. Avinash Supe, he is executive director, Hinduja Hospital, Khar. Welcome, Dr. Supe. Dr. Ashwini Jogade, she is a medical superintendent, Nanavati Max Super Speciality Hospitals. Welcome, Dr.
Namaskar.
Jogade.
Welcome.
Mr. Neeraj Lal, Chief Operating Officer, Apollo Hospitals, Gujarat region. Welcome, Mr. Lal.
Hello. Namaste. Wish you all a happy World Patient Safety Day.
Thank you, sir. Dr. B.K. Rana, he is founding CEO, QAI, and will also moderate today's session. Welcome, Dr. Rana.
Namaskar.
Now, I would like to invite Dr. Sanjeev Singh for giving the keynote address on patient safety. Thank you. Yes, Doctor.
So is this visible?
Yeah. Yes.
Yes, Dr. Singh. Yes.
Yeah. So thank you so much, Voice of Healthcare and all esteemed panelists for giving me the opportunity. And thank you, Dr. Rana, for moderating. And it is so good to see all of you after so long. And I miss Dr. Sahadulla hosting him yesterday and would not miss the opportunity next time. So medication without harm is the theme, and it has a lot of its relevance, and we know that there is a existing problem. If we see, there are lots of accredited hospitals. There are 1,500 accredited hospitals within the country. And if you look at the data which is there of all the indicators which the accredited hospital submits to NABH, you look at medication error, it is at 0.04%, and internationally it is at 3.2%. And that is the problem, because we don't know the definition of medication error, we don't have adequate training, we don't have ethical reporting and documentation system. And that is where I think we have gone wrong. But then there are huge scope for improvement. There is also a national average, and then there are state representation of data. So good thing is that there is data, there is collection of data, but then there is a lot of improvement which is required. It is also dissected by each hospital and looking at each quarter vis-a-vis the national average and the state average. So there is robust gold mine which is available, but we need to act on it. Medication management has its own cycle, which basically starts from procuring, prescribing, preparing, administration, and documentation. And we would like to use this cycle for optimization of the medication. So how do we do that? There are various tools for medication management and medication listing. A good drug chart, whether it is electronic medical record or in a paper format, is a good way to get started, where the indication of the drug and dosing frequency and indication why it has been prescribed is extremely important. Then another important aspect is patient information card, because we prescribe a lot of drugs. There is the which also needs to have its recommendation, whether it's at the HS or it is taken before food, after food, inhaler injections, or any nutritional items. So that would be critical. And linked to that is a patient fact sheet, because information to the patient, the family members, and for them to take an informed decision making is an important criteria. So what does the clinician, why the clinicians have not been able to sort of help in this medication error and adherences issue? Because they feel it's all fine. They forget about the medication management reminders. Some of this, they can't afford the medications, the pills. There are many, there are polypharmacy. They don't understand the instructions. And we at the pharmacy college did a home health survey, and we realized in a state where 9% of our literate adherence to the pharmacy prescription was 42%. So there is a lot of scope for improvement. And then the same tool is required to engage with the practitioners to see whether medication adherence and their compliances are becoming better. There's a very good tool, which is AGS Beer's criteria, where American Geriatric Society said that there are few medications which are high alert and which needs to be cognizant. We need to be cognizant of the fact that the prescriptions should demand some concern, like heart failure, hypertension, gastric duodenal ulcers, seizures, epilepsy, insomnia. So these are all high priority severe rating scales according to Indian Society of Medication Management. This is the basic criteria which is good to follow. There are ADR monitoring mechanism, and I think Government of India has done a fantastic work. They have put in a national pharmacovigilance program, and all institutions are encouraged to participate. And there is a lot of decent data which is coming out to look at the causality analysis. Once the causality analysis is done on the Naranjo's algorithm, then there is a certain probability and possible cause of all adverse drug reactions are shared with the respective team, and also with a benchmark information. Similarly, there is an Institute of Healthcare Improvement which comes up with a medication reconciliation toolkit, which is called as MATCH, which is basically medication of transitions and clinical handoffs. So we do talk about handoffs, we do talk about reconciliation. Again, it's a good tool to get the medication management done and follow a good medication management practices. Is technology helping? So there are many good ways, and electronic medical records is a nicer way, and Dr. Sahadulla has been a fantastic proponent, and he has developed a lot of good things. This is what we do at our hospital. There are alert dashboards for the nursing care plan. There are you can easily add favorites on the right hand side. So if you are a gastroenterologist and you have a gastro specific medication, you just drag this, and then the prescriptions are ready, and the mistakes are less, where rate, priorities, and refilling and the drug dose are mentioned. Home medications, if there are any, to get at the reconciliation done at ER or at the transition points, can also be recorded, and that is, again, it adds on to a good medication management practices. Medication verification is also important to understand that which are active, which are deleted, and which are not repeat all. Kind of a practice where pharmacy is verified, nurse verifies it, suspended molecules are understood, and then order, start date, and administration date are seen. There are pending medication management schedules where all red is past due, all greens are due, and all P are PRN status. And that immediately gives you a greater understanding when you go for rounds for a critical care unit or an inpatient unit, to have a bigger understanding of how the patient is performing and vis-a-vis the medication management. There is also this 5R check, which right indication, right drug, right dose, right frequency, and right duration, which is also helped with an ERX module. But then there are other technologies like MediSafe app, Docast, Care Clinic, Pillbox, which gives you a reminder. And then this, especially for those who are chronic patients, So these visual displays and symptom tracking and flexibility and some of these free app, and it is extremely handy to these patients who are on a longitudinal care. There are some motivational interviewing mechanism to understand how best we can implement GMP. There are some technological advances which have also been done, like smart pill dispensers, electric pill boxes. So where the storing, type, strength, medication optimization is all information is given, and it is shared in the individual mobile. So there are digital pills which are available. There are some institutes which have also adopted automated medication dispensing mechanism, a robo, which picks up an ERX prescription and also dispenses it accordingly. So there are fantastic ways that the world has adopted to see what works best. And I think that is where this particular meeting and meetings like this on a World Patient Safety Day is extremely important, that we contribute towards patient safety and at least work towards medication without harm. So thank you so much, and over to you, Dr. Rana.
Thank you, Dr. Sanjeev, for your insights. So without further ado, I would like to hand over this session to Dr. B.K. Rana to lead this session with the co-panelist.
Thank you, Ritika. Thank you very much.
Dr. B.K. Yeah.
Thank you very much. Thank you, Sanjeev. Wonderfully laid out, very crisp and crystal clear presentation. That's the property Sanjeev has it, right? So thank you so much for that. And I think I'm really honored to lead this panel with the eminent panelists, Neeraj, Avinash, Dr. Sahadulla, Ashwini. Am I missing someone? No. Okay. So it's really honored for me. And I think building on what just Sanjeev finishes on a very illustrative thing on an automated system. Sanjeev, in a hospital setup, there are clinicians and surgeons prescribing medications left and right because that's required. And every hospital might not have a HMIS, right, or a software system to do it. And so there are writing, in prescribing manually. So what do you think that the prescription audit can play a role in ensuring patient safety? And also, how you see that while prescribing medication, how you can suggest to help the physicians to reduce their burden? Means it's like in a two-way traffic, I would like to say. Their prescription is okay, and that you can check through the audits, and then their burden is also in writing so many medications, keeping everything in mind that they are not prescribing something which they should not be. So how they can balance? Just over to you for those thoughts. Thank you.
Yeah, thanks, Dr. Rana. That's a fantastic question. I think it is important, as you rightly said, that hospital information system is so limited, and there are 75,000 hospitals in the country where HIS or EMR would be very limited. And it is important that we need to follow, which is where minimum standards are adhered in most of the hospital. NMC, National Medical Commission, gives a good guideline where most of these medications needs to be legibly written, needs to be written in capital, and needs to be written in generic. And as you rightly suggested, prescription audit is a good way to understand whether it has been done. The legibility, the timeliness, and the dispatch, the dispensing, and the transcription, and also administration, whether all of it is happening appropriately. It is also at this point of time important to understand that there is a definition for medication error, and there are 9 types of medication error, which is not adverse drug reaction at all. So unfortunately, everybody waits for this, and there is where we don't report. So prescription audit is a very good mechanism, and that needs to be done, and also needs to be where the physicians should be engaged and should not be seen as a finger pointing mechanism. The next question which you had asked is there any mechanism where we can reduce the workload? I think there is a good group of people which I'll call a clinical pharmacist, which are not B Pharms and M Pharms. They are Pharm D, 6 years of course. Very, very good resource. We have used them in most of our clinical setting where they take rounds and also are very cost effective, because what they deliver at the bedside improves clinical outcomes and gives a lot of valuable valuable inputs to the clinicians.
Thank you, Sanjeev. I think that makes sense, that how we can make use of the existing resources. We keep saying we have the scarcity of resources, but whatever we do have, we can optimize those use and then can reduce the burden of our physicians in a hospital. Now, taking from the institutional framework, which Sanjeev you had just mentioned and described, I'm just taking it to the next level, on a health sector level, basically, or and a healthcare delivery system level to Dr. Sahadulla. Dr. Sahadulla, my question would be is that what you think, in your opinion, in your experience, you are running hospital chain and for the last several years. So what is, in your opinion, then things can be institutionalized in relation to medication safety? We are talking specific to the medication safety and a healthcare delivery system, not just in a hospital, but as a complete healthcare system. So over to you, Dr. Sahadulla.
Thank you, Rana. Good evening to everyone. I think I would take it from where Sanjeev Singh left. Whatever he mentioned, we have to practice, and that part is the most difficult part. We can talk about all the theory part, but the medication is prescribed by only one group of people, and that we are the people, doctors. And the medication is administered by the nurses or the doctors themselves. So these are the two groups of people. If you focus, the medication errors can be made to a great minimum. Of course, pharmacy dispensing errors are also there. So if you want to elaborate, it can be three groups of people. And in my opinion, repetition is the best medicine. We have to keep repeating all the methods by which the medication errors can be reduced to these three group of people. The clinical pharmacist, as mentioned by Sanjeev, especially in reconciliation and in the medication auditing, they are really helpful, and many times they are very, very inexpensive, and every hospital should employ them. Automation is a second method by which we can definitely reduce it to a great extent, and but we should not just depend on just EMR. And we fortunately have EMR, and we have CPOE. CPOE is an effective method, so by which you have to prescribe the drugs on the computer, and the possibility of medication errors is much reduced by automation. But when we give verbal orders, we always insist that should be repeated by the person in an emergency situation. Only that happen, and then we ask them to repeat the medicine, and even if it's a doctor who is writing at the other side of the telephone. So look-alike and found-alike is an important thing, and those high alert medicines we should be very careful, and so it should become a second habit. In what I do in oncological medicine is a three-tier system. I'm sure all of you are doing it. I'm only repeating it for the sake of completion. Three-tier checking before administering is by the pharmacist, by the doctor, and by the nurse, two nursing who is taking it, preparing it, and also the nursing who is administering it. So in fact, not even three, sometimes it's a four-tier system, and that's what we follow. One of the other things is that we find that nurses are often disturbed And we are trying out many of our areas wearing a vest of a color vest for the nurse who is administering the medicine. And this is just like we follow the airlines, aviation, and we take a lot of lessons from aviation and a relative silence and do not disturb me. I'm giving medicines, and it often works. And they definitely, we found that in audit, they make less mistakes. So in short, the important habit, unfortunately, most of our doctors have not inherited so far is the generic medicine. Instead of writing the trade name, just write the generic name. And if that can be, I think National Medical Council has said it, Government of India has said it, and if doctors can follow that, that will definitely will lead us to a lot of medicine safety. So these are some of the methods I can mention from my memory that we practice in our hospitals, which has reduced medication errors. But certainly, once the medication errors will occur, the P&D committee and the quality committee, they report it as an incident report, and also we take it and study that and try to see that is at least not repeated. So thank you. This is in short, Rana. Yeah.
Thanks, Dr. Sahadulla. I think you well covered a range of activities, parameters, which can be taken into consideration while we look at that. But realizing the fact that the hospital particularly is a complex environment, and the chances of error at different stages of medication might happen. Despite you mentioned we follow airline system that you have a color coded jacket and written at the back, "Don't disturb me. I'm preparing medication" or something like that. But it's still, But I'm taking very, very important cue from you and the presentation made by Sanjeev, and beautifully, illustrated graph saying that 0.04%, something like, of medication error, which is where the international average is 3.2%, something like that. So it means we at India are far beyond an expected limit of errors. But that's not the reality. That's not the reality, actually. Maybe something wrong in our measurements, something wrong in capturing the data, or we really don't know how to capture data and what to capture. So I think just moving on those lines to Ashwini. Ashwini, my question to you would be is that you have seen the vast situation we have in our country, right? And a similar situation everywhere around the world. So what do you think is the overall impact of medication error on patient safety? Because ultimately, either beneficiary or harm is being is going to the patient. So how do you see the impact of medication errors on patient safety? Over to you, Ashwini.
Thank you, Dr. Rana. Thank you, 𝗪𝗧𝗪𝗡 Global and Voice of Health, for inviting me as a panelist. This is indeed a very important topic. And thank all the panelists here. Welcome all the audience who are attending this session today. And at the outset, yes, we wish each other and all of us a happy World Patient Safety Day. And this time, really, we have taken the initiative. It's a very, very important term which we have kept on using it today, the entire morning, is medication without harm. So unfortunately, as a patient's relative, or when I speak this to my non-medical colleagues, first of all, like when last 3 series, when we started this World Patient Safety Day, many of my friends, in fact, my brother used to say, "How come you say World Patient Safety Day? Isn't the medical fraternity, or isn't the institution or a corporate hospital, or for that matter, any primary healthcare, aren't they responsible for taking the patient's care? Why do you insist, or why do you embark upon this World Patient Safety Days?" So, no, because gradually, by the time we all are learning, doing deep diving, a lot of brainstorming, and a lot of good reporting what we do with the jest culture, we all have now come down and narrowed down many points that yes, there are at many touch points wherein we can avoid, there are many avoidable causes wherein we can contribute to patient safety. Like many other parameters, we have the IPSG goals, and out of them, one is medication errors, prevent medication errors. So, we had a very beautiful presentation at the outset, wherein all the details were mentioned about medication errors, and then Sir mentioned about institutionally how do we have this medication nurse, and how do we build in this culture and prevent medication errors. Especially PTC committee or quality team at every hospital will be doing that. But if I just take this opportunity and to respect to Dr. The question what I have got, I would just like to first, for the benefit of the audience, who there might be many, very few who are hearing it for the first time, like, medication error. So is it that medication error is something wherein it has caused harm to a patient? Is that the definition? No. So just for the clarification, as I have to answer an important question of impact, just quickly I would like to take to the definition that a medication error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of a healthcare professional, a patient, or a relative, or a consumer. So broadly, this is the definition. So it says that yes, even if it is the patient at home, or there's a pharmacist who is still in the pharmacy, or there's a nurse who is yet to administer, or a patient who is just about to ingest the tablet, or there's someone who is yet to inject the medicine. There are various touch points and various preventable aspects wherein we can prevent medication error. So the definition goes from no error, like Sir just mentioned, there are 9 categories. It could go from no error, no harm, and yes, there is error and harm to the unfortunate cause that it can contribute to the patient's death. So various 9 touch points are there. If we collaborate everything, I think last, if you see, everything is available on net. WHO site has beautiful definitions. There's a beautiful dossier which we kept on reading, and we keep on training our doctors and resident doctors. So if we see, for the benefit, there are various studies to see the impact. As a definition is very broad, there are multiple aspects which are getting covered. So various articles wherein I will just summarize 5 or 6 important articles or quotes wherein we can see how huge the impact of medication error is. To start with, when I just read the dossier which was in WHO website, with due respect to that and mentioning the site.
I'm sorry, I'm stopping you, Ashwini. I'll come back to you on that references, because that has another question linked with that how we link the systems, the knowledge which we have, the literature which we have, but are we using it? So I will come to you on that. But I'm linking what you just mentioned about different types of combinations and, different mechanism for using the medication, different touch points for in hospital for medication error. Now I'm leaving and connecting your points with the Sanjeev's presentation of HMIS. Sanjeev, I just come to you if you're there at the moment quickly. I realize the fact of the time that what do you think in terms of patient safety, again, in relation to medication safety? Our clinical decision support systems, like you have HMIS or something like that, can they help? And if yes, what's your thought on that? Thank you.
So CDSS, I think, is a fantastic tool which should be adopted by every hospital. And I think 𝗪𝗏𝗧 have done maximum work globally. Especially CDSS should be adopted for medication management, which is almost a done deal. It's a very mature system where for any, like if you take an example for any chronic illnesses, maybe diabetes, if you look at or you prescribe a drug, it gives you an alert whether it's a right prescription. So first it links it to the lab information. So whether the glycosylated hemoglobin was appropriate to be able to prescribe an oral hypoglycemics or or an insulin therapy. Second, it also then helps you to look at drug interaction, or a similar family drug was already given. So it gives you an alert that don't prescribe because there is, or at least check. You can revoke that decision. Third, there is many a times food drug interactions. So it gives also an indication that you need to watchful or at least advise the patients on some of the restricted diet habits. Fourth, it gives you an example of any possible side effects or alternate effects, so that at least you know this as a patient information and share it with them. So it is such a fantastic tool. Plus, it also gives you a reference. So it gives you a reference of it is taking this particular from AHRQ or WHO or CDC. So you're not just beating around the bush. You are looking at an evidence-based medication practices, and this is a good way to go ahead. I think CDSS is a fantastic tool which should be adopted.
Thank you, Sanjeev. Thank you for your insight on that, how we can leverage on technology, available information, data sets, knowledge, wisdom put together in a system to make use of giving us alert. And I was talking today in a conference on telehealth that how we telehealth provider can use AI ML. You know, everybody is talking about AI ML, artificial intelligence, machine learning, but do we really understand the meaning? You know, but they want everything to be done by AI ML, but it's not. But they can be used for the things which you just mentioned to give. When you write a medication, it can alert you know patient is allergic to it as per the history told, you know, that this may have a drug interaction, this may have this thing. So I think these are important tools which can be leveraged on adopting for the better decision making as well as a patient safety. So thank you very much, Sanjeev, on that. Building on the same again in a row, I'll come to Dr. Avinash at the moment. Dr. Avinash, now how important is reporting? You know, we talk about the errors, medication errors happening. They are happening. Somebody reporting, some may not be reporting. Okay. There's some errors may be leading to adverse drug reactions, some may not be, or some events or some ADR, ADE, and all sort of things happening. Some may not be having anything. What is your opinion on reporting of ADRs and ADEs? Is important in improving the whole scenario of medication safety.
Thank you, Dr. Rana. I think it's such a wonderful question. If you know, I think you talked about we are reporting 0.4% when the world is reporting 3%, and I think that's gross underreporting which happens in India. There was a very nice paper in Indian Journal of Pharmacology in 2015, which said that we are underreporting, and when I was in KEM, we had a very strong pharmacovigilance department, and we used to have a pharmacovigilance program. So what I realize is that when we look at India, I think there is a lot of underreporting of this occurs. Especially, you will find that most of the contribution is from OPD. There is a maximum contribution from internal medicine, oncology, and chest medicine. While it was surprising that most of the surgical disciplines never reported any AE, and which is very unlikely. And in fact, many sectors did not really report any adverse drug reactions, or ADR were not reported. So the whole question is that if you do not record, then you are never able to analyze from what are the drugs happening, and you are never able to know. Say something we go on doing so grossly. For example, to give you example, this year, semaglutide was really introduced in our country. It is actually a drug for diabetes, but it has been used for now obesity. And within, say, 6 months, the company's turnover has gone to about 100 crores. But there are so many patients coming to us with so many their reactions, their side effects, which have not been recorded and neither reported. So we sometimes don't report properly, which has a great impact onto how these medication errors are probably put under the carpet, or people don't realize, as somebody rightly said, we only think if it gets allergy or reaction, then only we call it. The other wider aspect of ADRs are not reported. So there is a need for educating people, make them realize, make the whole system very easy so that people report. And then we get the data which we analyze, and then we probably can guide the authorities, hospitals, or these are the common errors. This can be prevented at this level. I think every hospital does prescription audit committee. In fact, I feel we have been doing it regularly, where I realize that if you focus in a one area where the errors are more, I think we can make definitely an improvement. So it's a persistence, analysis, and then try to have a focused action after ADR reporting would make a lot of change. So I think therefore ADR reporting is absolutely essential, and everybody should be alert and vigilant about this. to prevent medication without harm. I mean,
Thank you, Dr. Avinash. I think wonderfully captured that how important it is to report. See, unless somebody says is wrong or right, how we will make a decision, right?
sure.
And if somebody knows that yes, instead of giving 2 mg, I have given 4 mg, and not reporting, so patient is going to suffer in any way.
Sure.
So reporting makes a very, very important aspect of any safety mechanism, and that's why world over it is being practiced that there should be a non-punitive reporting system, encouraging the staff to report, not to penalize. Otherwise, no one going to report. But how truth it is, let's try to understand that what Neeraj think about. He is running a chain of hospital, you know. So I would come to Neeraj and ask question that what is your opinion then use of use of technology, how we can make use of technology in analyzing the data or the information which we have, or any technology which is evolving at the moment for the betterment of the patient care to reduce harm to patient, in particularly in relation to the medication errors. Over to you, Neeraj.
Thank you, Dr. Rana. And it's mean to me, the quality person of India is talking about these things. It is very, very important. Dr. Sanjeev, impressive presentation, and congratulations to you and team Amrita for the wonderful large hospital in NCR region. So that is a great boon for the patients. Actually, we are doing everything I have seen, in different part of India, but I think we don't talk about data. Like we as a PNL head of the hospitals, if you see after heart disease and cancer, the third leading cause in United States is for medical error. It is not in India, but in India, it remains mostly undocumented. And I think the things which is not documented, it is not taken care of. Thanks to this days like World Patient Safety Days, for the last 1 week, entire Apollo group is talking about this. Like in the morning only, we did once a skit where all these staff nurses, 6 type of medication error, they actually are doing a mime and skit to teach every patient attendants and the staff nurse at large. So it actually means what you see it is actually happening. Like say for example, we have got so much of patient database, but whenever doctors go to the conferences, according to American society, according to European society, look guys, we are 140 crore Indians. Our doctors are doing medical miracle every hour, but who is reporting them? I would love to see one day, according to Delhi Medical Association, according to Bangalore Medical Association, and so on. But we are not documenting data. We are doing great work, but somewhere it is not happening. So don't feel 2.5 lakh people die in US every year due to medication. But in our country, it must be huge, but we are not reporting it. So that is the main thing. Information technology is a key. I think COVID has taught all of us. If we use technology, we can measure what we are doing and what are the things to be done. Thanks to this COVID, now Indian hospitals are making use of the technology. System that can be used for the technology, like we in Apollo use computerized physician order entry. Physicians are talking to the patient more and automatically a prescription is generated. We track the prescription. We got a team of PharmD people who monitor every prescription which is generated, which is known as PAT teams. It is not EBITDA after tax. So they used to monitor every prescription. And sometimes it has been seen, they also call back to the doctor and say it is wrong or right. Automatic dispensing. India is a big country. We have to use automated dispensing, barcode medication, and all those things. In Apollo, we got a culture. We do a safety meter. Like every year, they do a safety score trend. Say, for example, for Apollo Hospital, Gujarat region, in the 2020, we are at 58. Last year, we were 68. And now in this particular year, 2022, we are 70. So it shows the trend of overall safety trend, like patient safety, grade, incident reporting. And you will be surprised to know, Dr. Rana, the maximum thing, the people don't report. We were talking about communication openness, feedback and communication about error, handoff and transition. These are the various parameters. So a centralized team, they call all the people. So for example, Apollo Ahmedabad, 1,175 people responded. And percentage of respondent who didn't report any incidents in past 1 year, It ranges from 54% to 49%. So if awareness is not there within the healthcare staff, then what about patients? So I think some of the hospitals are also involving for this patient safety day, the patient and their attendant also. So if we use technology, see, I can talk about technology at length. You're talking about AI, ML, there is electronic medical reconciliation, there is personal health record, there are medication dispensing station. But awareness is a key. I think after COVID, we all are washing hands. You go to a small shop, they also give you a thing to wash your hands. So if we use technology, and very good example which is given by Dr. Sanjeev Singh about PharmD. PharmD, so many pharmacy colleges are there, and no hospital is making good use of them. We have a batch of 18 to 20 students coming there for six months, and they're posted in various wards. So thanks to these students, which is taking care of our medication error, and entire pharmacy department and medical department is taking care of that. I think if we use technology, our 66% is CSP, that is care suite persona. Our prescription which is generated for Apollo Hospital in Western region is more than 60%. If we use e-prescription and we see patient and talk to more patient, I think we can able to do a good job in the interest of patient safety, and then we can reboot the patient safety in each and every step what we care, which will be given by a doctor.
Fantastic, Neeraj. Thank you so much for very, very exciting deliberation, Neeraj. Now, my point is, technology plays important role, can do wonders. And I give you an example, the real example. One of the best hospital, without naming, one of the best hospital in the world, in United States, having a lot of medication errors at dispensing as well as administration, okay, to the patient. And what they did, they got a design, a automated system for dispensing medication. It's like a big refrigerator. The nurse will take the barcode. Every patient has a barcode identifying. So it's nurse will take the barcode to the machine, scan it, and the drawer will automatically open up with the amount of quantity of the medicine which need to be taken off. So nurse will pick up those medicines for the dose and go back to the patient and give it. So this was a perfect system, So you will only take those medicine which are required for that specific patient with the same dose, and you will deliver it to the patient. Now, after some time, hospital found the errors are still happening, and they wonder what was going on. And they found that the nurses are very, very innovative. What they were doing, they were taking more than one barcode, and they were putting under on their hands, one barcode, second barcode, third barcode, and then put the code or lab code or the nurse code over there, so nobody can see it. And they will go to the machine, scan the first barcode, they get the medicine. Again, second barcode, third barcode, fourth barcode. So 4 patient barcode scanned and get the medicine. Now, can you assume what will happen at that time? 4 patient medicine in their hand. Now, she will not know which patient, which medicine. This was the innovation by nurses. So machine can play, technology can play important role, but until unless human being don't use it appropriately, no technology can help anyone. That's my belief. So what they did, they put a time gap in the machine that after scanning one barcode, you cannot scan second barcode after this. You have to wait for this. And so nurse has to go back to the patient and give and then come back. That reduces their medication. This takes me to the next question to Dr. Sahadulla. Dr. Sahadulla, what's your take on, like Sanjeev mentioned about this clinical decision support system, some automated system, software, HMIS, and whatever system. What you think that these type of system can help in reducing the cost burden, which is due to medication errors on hospitals? Over to you, Dr. Sahadulla.
Yeah, I think it was very well elucidated by Dr. Neeraj, and very good practice in Apollo. We also do electronic prescription. We also do the computerized physician order system. And in all our hospital, the barcoding of the medication is the only thing which is not possible to be done in India, because the pharmaceutical companies are still not coming out with the strips which are barcoded for their own commercial reasons. And so a large amount of medical safety is assured by automation. And if we can really connect the CPOE and the EMR by the CDSS. And we can get even the doses coming out, as you were saying in the US. I have seen the same thing happening in hospital I worked on time in Aramco. But only thing is, it is so time consuming to come and take it and give it and administer, and that's why it is not so widely practiced and even not insisted by JCI courts and the CPO. That can really give a standardized order sheet. And if you get the standardized order sheet, even according to the weight of the patient and the age of the patient, the doses can come in. And then, of course, another thing which can pop up is we have one, but not perfect enough. That is the drug interaction. Drug interaction is a major area, especially in this age of polypharmacy. Every cardiologist, or I don't want to pick anyone, but most of the doctors write 3 or 4 medicines, and they will be all interacting with others' medicines or the same medicines which we give. And so I think medication error, as you said earlier, reporting, auditing, and automation and awareness creation is continuously have to happen. And I also agree to your statement that we are undercoating a lot. So we have to keep on trying to make it a work culture and a second habit, and then only the medication error can change. And one more thing, one of the essential thing I advocate is, please avoid polypharmacy as much as possible, and also write generic names, and that will reduce a good amount of medication error happening at this point of time in our country.
Thank you.
Over to you, Doctor. Yeah.
Thank you so much, Dr. Sahadulla. Well said. I think that summarizes a lot of issues around recognizing the fact that in our country, we also have some limitation in terms of resources. So we cannot expect everything to be of high end, but whatever we have, how we can minimize and work along to make sure that things can happen in a better way. Taking that cue from their point, Ashwini, I come to you. We are talking about technology, we are talking about clinical decision support systems and like systems. What is your take on using technology for the benefit of hospitals, patients, and clinicians, all having the single aim to reduce the patient harm from medication errors?
Yes, sir. Thank you, sir, for the extended question. First of all, I really appreciate the example what you just now gave of the barcodes. That's where we all, as an administrator, we learn that whatever technology we bring, but a very nice observation, somebody is doing this 4 barcodes for the work efficiency. Excellent for all of us to learn. This is also to say that even if we use a lot of technology, it has to be synchronized. The end user has to accept that. The doctor, the patient, the staff, and ultimately the patient have to accept that. And yes, with this in advanced age, especially after in COVID eras, wherein this clinical decisive tools helped us a lot in learning a lot of new medicines. We used to get a lot of information, and then we used to have this brainstorming sessions, which medicine is safe for our COVID patients. In case of comorbidities, which patients we can prescribe what type of medicines, especially when remdesivir and all things were going on. So if we say automation, yes, for the hospital, what are the benefits? It becomes very easy, especially for the prescription audits, for your internal tracking mechanisms. If someone is using a high alert medications or costly medications, are they getting it delivered properly? For the administration, for the institution, it is very, very important tool. But yes, as you mentioned, sir, same way synchronization and acceptance has to be there. Then for the doctors, how is it useful? We all have lovely handwritings, and we all know that only pharmacists and bare nurses can read. So in such cases wherein we have a EMR system and wherein we have technology at our desk in OPDs and IPDs, we all are used to know a lot of drop down comes. It becomes easy for the consultant also to prescribe the medications wherein the doses are automated. There are less efforts, there are less errors, especially with the new recent tools. We also come to know past history of patient, we get automated captured. If any adverse event has been occurred in the past, that also might will get captured. Any drug food interaction, if it is there, that gets captured. And medically, these decisive tools help the clinicians also to update their knowledge. So yes, it is also advantageous to clinicians also. And for the patient, yes, because they get a good printed report. Many of the EMRs or many of the e-prescriptions, when they go home, they have a ready a reckoner, a printed report. And there are various apps, as Dr. Sanjeev also had mentioned, that because of these apps or maybe some tools which are given for patients, it becomes easy for them to understand what medication has to be taken at what time to avoid drug interactions. So this is a holistic benefit of technology. And yes, sir, using AI, we can still develop many tools in the future for the patient and the caretakers also.
That's good. Thank you so much, Ashwini. I think there are lovely discussion, and I give an example. I have example. Yesterday we had our accreditation committee meeting, and one member shared a real example of prescription.
Nice,
Prescription one is about when there was a doctor prescribing medicine, and nobody was able to understand what he was writing. So one day somebody approached him with the request, "Sir, can you please start writing in capital letters?" And he says, "This is what I was doing till now." So even his capital letters were even like that. So this is how the human interface is. And so, but I'm taking the lead from the technology and building on that, because this is an advancement which we have. I'm coming to Dr. Avinash with my questions to him about that, how we can really we give examples of Western world always, compared to CDC America or for NICE UK or something. So in same scenario, in relation to adoption of technology to reduce medication error, can we learn something from the developed countries? What is your take, Dr. Avinash?
I think, Dr. Rana, that's a wonderful question, I must tell you. I think we have been watching CDSS since I remember 1989 when it was first used in reads. But over a period of time, I realized that this was never extensively used and there were a lot of flaws which were always put forward. But I think over the last, decade, there has been a lot of revamp, and during COVID, again, a lot of things came up. And I think 𝗪𝗪𝗪𝗪 has come out with 4 programs, which I'm sure, Up2Date is used all over India, but Lexicomp and ME and MedSpan are not used. And there are some alternatives by others also. Now, your question is very specific, that what is the world Western experience and how do we adopt our technology into this? Now, see, if you see, there was a very nice paper in Nature, which I remember I was very keen to read about it. And it talked about what do we learn from the CDSS, what are the various problems and what are the mitigations and solutions for this. And they had a wonderful kind of a thought process. Now, see, when we started using, there was a first question he said was, people have alert fatigue. Alert fatigue is a very well-known thing in this. It's good to know about technology, but as you know, people always adopt this technology. They will put up this alert. There'll be too many alerts, so people don't use it. So the first question people learned in the West was alert fatigue. So they started now changing their programs in such a way they're prioritizing alerts. So now you have to integrate it with your EHR and then now try to see how we can integrate and you try to achieve. So people are trying to do CDS solutions which are as per the thing. So with whatever Western world is trying to, and there are many things like this. They are trying to integrate with lab, they are trying to integrate with EHRs, they are trying to see what are the Indian situations. Now, when we are going to learn this, we have such a great potential, but I think we are not using it so effectively as CDS in our country. But if you have to use it, we have to really see what are our conditions. Many times our patients have low weight, cost is an issue, cost containment is a big issue in our country because it's a hugely costly affair. And secondly, educating the whole healthcare staff and trying to see there on the board, especially for these kind of alerts, is a big problem for us to CDSS. And therefore, I think very few big hospitals, corporate hospitals will be able to adopt it. But many of these kind of things will probably lag behind many years in our country to get adopted into this. But I feel if you want to adopt these technologies in our country, we need to think what, again, as I said, again, we come back to area reporting, analyzing, focusing, which are the areas where we need to make a change and where we need to use technology like this. That's where we should use technology more effectively in the beginning, and then take over to the just trying to adopt their Western programs. Something like Ashwini was saying, try to use holistic patient care programs like ME, rather than trying to just use a prescription where most of our doctors say, I do not agree with this kind of a treatment. Then you try to look at the holistic programs where you look at, like for example, it's a very common thing in my OPD, a patient will come, 70-year-old, we have 6 prescriptions, and then she's saying, doctor, there are so many drugs I am taking. You're talking about polypharmacy, and nobody really checking their drug interaction and everything. So I think there is a need for systems to tell us, okay, this is where this patient is on anticoagulation, you are giving this drug, it will affect his coagulation system. These alerts should be prioritized, they should be given, and there has to be a holistic planner. So I think there's a lot to learn from the Western experience, and we need to take it further if you want to adopt in our country.
Thank you, Dr. Avinash. Thank you very much. I think lovely discussion, very exciting. I'm really excited when I talk to people like you and a group like here, giving me so much knowledge and wisdom. But again, I keep challenging people, particularly for technology-savvy people, that human being can defeat any technology. Coming to the example you gave, an alert system, you have alert system, yes, allergic, food, drug interaction, food, after, whatever it is. Now, I have seen, and I'm giving you, these are not a philosophical and hypothetical, but the real examples of my experience visiting there is a hospital visited where there's a system exists, like you mentioned, right? There is an alert will come in the HMIS when they prescribe something. There are too many alerts will come. There is a system for disabling those alerts as well.
Yes.
And there is a doctor who disabling these alerts. So now once, for some reason, he disabled, and then he's not getting any alert, so he's continuously making whatever he wanted to do it. So until unless
new solution will create new problems after some time.
That is what, because those solutions become problem for the individual. They think this is a problem, so I let it get away with that. So I think that is what it is. Use of technology, I keep saying, should be used as a support system to human beings. You remain the leader to decide. You have to drive things, not the technology. Technology should guide you, advise you, support you, whatever way. But finally, you say, I am the boss. That's my way of thinking again. But before I make anything on that, I'll come to Neeraj. And I think the most important question at the end, almost at the end, I'm going to ask. We talk about technology, we talk about different system available, we talk about human being, we talk about errors, we can talk about safety and healthcare system. Now, I'm talking about everyone. And when I say everyone, it means stakeholders. Stakeholders play important role, and it's up to you how you define your stakeholder. You can just define patient, or you can extend patient to doctors, to nurses, to your insurance payer, or anyone community, anyone included. So Neeraj, my question to you is that what do you think, what role does healthcare the stakeholders can play in minimizing specific thing I'm asking, medication errors? So how you define stakeholders and how you can make use of them in reducing the medication errors in your hospitals. Over to you, Neeraj.
Okay, I think since we have a safety culture composite, so over a 72 hospital experience, I think non-punitive response to error, I think handoff and transition, these are the two things. If it is done properly, I think important patient care information is transferred across hospital unit during the shift changes, and it's still on a manual mode. I'm not talking about use technology there. I'm talking about the non-punitive response is very, very important. I think people, medical administrators, healthcare administrators sit and talk about staff nurse, and a poor staff nurse do a better job than any other person in the hospital. I think she's with the patient, she owns the patient. I think a safety culture has to start from there. Staff nurses, that is a key thing. And if we remove, because in all our safety survey, that is number one point which has come. So I think if we can take care of these things, a safety culture can be anything which is good to great.
Thank you so much. I think, Neeraj, you said it right. The culture of patient safety is the most important. That need to be developed in each and every healthcare provider, healthcare worker. Then only it can be achieved. And I think you would appreciate that in medication, starting from prescription. No, I'm not talking about before medication come to hospital, but before after that prescription, then dispensing, and then administration. At least 3 stages patient goes through till it is making any error or any harm to the patient. So right time, right dose, right patient, everything is right. So right time. So I'm mindful of time. We are hitting 6 o'clock. So we in a quality domain should respect time as well. And I think we have covered almost all my panelists with equal questions, if not less or more. But my take would at the end would be to think and summarize that when we talk about patient safety in relation to medication errors, we have to pay complete attention to all these 3 stages: prescription, dispensing, and administration, right? All 3 stages, because if you catch the problem at the end, still patient is safe from any harm, potential harm. Okay. Second thing, being coming from an accreditation background for last 20 years, running accreditation bodies, we believe in standards, right? But the standards can't do magic without implementation. You may have beautiful standard, maybe NABH we started. Now we have QI standard, dozen of standard in QI. We have JCI, ACHS, numerous accreditation bodies world over. They have all standard. But implementation of these standards in real sense in a hospital makes a lot of difference from one hospital to another hospital. So I firmly believe in implementation science. Implementing means practicing what you say, what you like, or what you document. So if you say you want to make sure your patient remains safe from any medication problems, no medication error, we have to implement those practices which you guys have just described in last 1 hour. Using technology, using any system, sophistication, your own knowledge and wisdom, resources to your optimal uses, and whatever not. So I think at the end, if we want to make sure that our patient remains safe, you as a hospital service provider want to make sure you provide safer care to your patient. I think in addition to what you just mentioned and doing implementation of what you said as a policy, what you said as a procedure, you said yourself, I may as a hospital can set up a fully manual system because that is the only resource I can afford. Dr. Avinash can afford fully automated system. Sanjeev, Dr. Sahadulla, Neeraj can afford, Ashwini can afford all fully automated system in the world. But there are errors happening in those sophisticated systems as well, as I gave you an example of. So I think we come together in a quest to achieve better patient care, better outcomes in terms of medication safety. On this day of World Patient Safety Day, we are celebrating medication without harm, which is actually global third global patient safety challenge after hand hygiene, clean care, safe care, then safe surgery saves life checklist. Third medical challenge is medication without harm. No check, ask. Doctor should also no check, ask before writing, and patient should also say no check, ask before taking. And I think I'm from accreditation background. You people are from the service provider side. I think role is on both sides of us to make sure that how we can work together, collaborate in a better sense to get the better outcomes. With this, I would like to thank Neeraj, Avinash, Dr. Sahadulla, Ashwini, and Sanjeev for your wonderful participation. I really enjoyed your company for last 65 minutes. It's really an honor for me to be with you. We may not be met before, but we met today, right? So thank you very much. Thank you, VOS. Thank you, Walter Kluwer, for bringing us together in this deliberation, which we aim to have better patient care in time to come. Thank you very much. Thank you. Have a nice day.
Thank you.
Thank you, sir. Thank you.